Hello, this video is going to be about partial nephrectomy. Partial nephrectomy is where we remove just the part of the kidney where the tumor is and try to leave as much normal kidney tissue as possible while removing the entire mass or tumor. I described the logic for this, choosing what to do with your mass in the first video. So please make sure to watch that. This is more about what to expect if we're going forward with a partial nephrectomy. So the partial nephrectomy is done robotically. All the incisions are small, which is great. The pain level is very tolerable. A lot of patients do not need any sort of narcotic pain medicine after a partial nephrectomy. They're all 8 millimeter incisions, except there is one incision that's extended. That's right here. And that's just extended to however big the mass is. So if their mass is 4 centimeters, you're going to have a 4 centimeter incision. The other incisions go along rib here. So there's like 1, 2, 3, 4. If it's on the right side, there's a fifth incision to hold the liver back. The surgery takes 2 to 2.5 hours, generally speaking, under anesthesia. It's a total general anesthesia with, an airway, paralysis, and everything. So it's a full major surgery. It is done in the hospital, and there is a stay in the hospital afterwards to recover. Generally, that stay in the hospital is 2 days. For partial nephrectomy, pretty much it can be one not overnight. Some people, especially on the left side, they recover a little bit quicker. On the right side, there's a special piece of bowel called the duodenum that I have to move over to get to the kidney. And whenever you do anything to the duodenum, it can cause nausea. So almost all of the patients with a right-sided partial nephrectomy stay for 2 days. On the left side, some people wake up and they're just perfect. uh, and they're having no discomfort and their, bowel function really is unchanged and they go home the next day. It's most people stay 2 nights. And you're going to stay as long as however long as you need to stay. There's no like, oh, he has to get out of here. There's none of that. Okay, it's completely objective in terms of your meeting criteria for like, okay, your pain's controlled, you're eating, you're peeing okay, all your vital signs look good, your numbers look good, and so then you are now ready to go home. If you don't meet those criteria, you are not ready to go home, and you will be staying. But most of the time, it's two overnights. Again, the surgery takes 2 to 2.5 hours. You'll come into the preoperative area, get you all signed in. You'll be there probably for an hour or so, then the surgery, and then afterwards you'll be in the recovery area for like an hour, 2 hours before you go up to your room. So the whole thing from the time that you walk in the door to the time that you end up in your room upstairs is about 5 hours. Most people go to the rooms directly above the operating room at Longwood, or there's a special postoperative unit at St. Lucie Medical Center, and generally they're private rooms or nice rooms. Some of the patients with more needs, like medically speaking, in terms of telemetry, if they have cardiac conditions, they may end up on a different ward where they have that capability. So it may not be the post-surgery rooms in that scenario, but most people go to those ones that are directly above the operating room. As far as risk for the surgery, in experienced hands, it's a safe surgery. The robot really helps. There is a 2% risk of significant bleeding, a 2% risk of infection, 1% risk of any wound complications, and a 1% risk of any injury to the bowel or surrounding structures. Overall, there's a 2% risk or 2 to 3% risk of the cancer coming back with a partial nephrectomy. And we talked about that in the first video. That's much lower than, say, doing a freeze ball or something like that. As far as bleeding complications, like I said, there's a 2% risk. When they happen, they're a little bit frustrating. They do happen, okay, because you are cutting the kidney out, the tumor out of the kidney, and then sewing things back up. Kidney tissue isn't like this, like wood that you can just nail together or something. It's, can be, we call it friable. It's a delicate tissue in some cases. So those things can happen. And so when that happens, that will extend your stay, basically. the risk of needing a blood transfusion for this procedure, like, is basically that's what the 2% is. There's a 2% risk of having bleeding to the point where you would need a blood transfusion, so significant bleeding. As far as a partial nephrectomy, there is always a risk that it needs to be converted to a radical nephrectomy where you remove the entire kidney. That's a less than 1% chance. Usually that's, there's some bleeding intraoperatively and you can't safely control the big giant vessels that are going into the kidney. And so you just have to remove the entire kidney. That's a less than 1% chance. Um, and so the reason why we talk about bleeding with these particular procedures is because, all out of all of the all of the blood that comes out of your heart, like your total cardiac output, your brain receives 33% of all of the blood coming out of your heart, and your kidneys receive 25%. So your entire rest of your body, besides your brain and your kidneys, receive less than half of your overall cardiac output. Uh, but your kidneys get a lot because they're a filtration. Basically, it's a filtration mechanism. So there's a lot of blood supply, and so that's just really something we're concerned about in terms of doing these operations. And so we have to get good vascular control before we start cutting on the kidney. Basically, I put a clamp across the artery of the kidney and then go ahead and do what I need to do. I have 25 minutes to do that without causing any significant injury to the kidney. And then I take it off the clamp when I'm done doing what I need to do. Usually, the on clamp time for our operative team here at Longwood and St. Lucie, honestly, they've done very well at getting this program started and going. So most of my clamp times now are under 20 minutes, which is fantastic. I don't rush it. So I do take my time doing the stitching and everything because I don't want to have a complication. But they're right there with all the supplies and everything. Everybody's on the same page. We have the same opera team, the kidneys, everybody knows these particular cases, the partial nephrectomies. There is a period of the operation where we are on clamp and everything is expected to go exactly the right way. They're fully aware of that. They have been introduced to that concept and they have responded well. So I'm very happy with that. And we've had some great outcomes. We've had basically good outcomes. We have a risk of bleeding of 2% that my numbers hold to that. It's a 2% risk. It happens 1 out of 50 cases. What else? So usually 2 nights in the hospital, and then for this scenario, I do see the mass. When I'm removing the entire kidney, I don't see the mass. I just remove all the fat around the kidney. I don't even see the mass. For this, I have to pull the fat back and get exactly, I might do an ultrasound of the mass while I'm in there. So I definitely see the mass. And I might have a little bit of an idea of, if there was something unusual about the mass or something. But generally, the imaging preoperatively is so good that there's really no change to the evaluation of the mass by looking at it intraoperatively on a gross level. The pathologist will then take it. It sits in formaldehyde for a few days, fixates in formaldehyde, and then they cut it all up and they look at it, the little slices under the microscope, do all their special stains, and come up with a diagnosis. That takes a week or two. That's why we don't really get that information as to the pathology for 2 weeks. And then when I see you back in the office, we'll take the staples out and then we'll review the pathology to see, if this is a cancer or not, right? Because sometimes you take out the mass and it's benign. So that's also something to know. 95% of kidney masses are malignant. There are 5% that aren't. And so we talked about it on the first video. Biopsy generally doesn't help. It's not worth the risk of biopsy. This procedure, removing the tumor itself, has a 2% risk of significant bleeding. Biopsy has a 2% risk of significant bleeding, and it doesn't give you all that great information sometimes. So that's why we generally don't do biopsy. If it wasn't small enough where it would be safe to watch, we are kind of just operating on a mass that we think looks like cancer, but sometimes it's not. So there is that 5% chance that we go ahead, do the operation, I see you back, and it's benign. And so that's a good thing, and you didn't have a cancer. But some people, it can be difficult to process. Well, then why did we do the surgery? Um, you know, that's kind of where we're at in terms of medical technology with this particular diagnosis, that there's a 5% chance that it's a benign mass. Um, and then, as far as follow up after that, it would depend on what the pathology shows. Almost never we're going to get medical oncology involved. Almost always, when it's small enough that it's a partial nephrectomy, that's it. And we do the partial nephrectomy. There's no chemo. There's no radiation. Okay. Um, and there's no chemo right away. We do get imaging afterwards, and we have to follow imaging for 5 years. Usually it's like every 3 to 6 months for the first year, and then every year after that. If there is like a spot that comes back, that is a good opportunity to use the interventional radiology technique of doing ablation, like that 2% chance that, oh, something shows up on the scan in the operative bed. That's like the perfect time to, okay, well, we'll just freeze it, just do the ice ball and take care of it that way. But we won't know to do that unless we're getting scans. So just make sure you're following up with either me or another urologist who has experience in dealing with kidney masses. I know a lot of people are going to and from when they're in Florida. And so if you end up somewhere else, just know that you have to continue to watch this for a full 5 years. So that's basically it. If you have any questions, just give the office a call. Have a good day. Sorry, one additional thing I forgot to mention. Uh, when you wake up from surgery, you will have a drain coming from your abdomen and a catheter coming from your bladder. The catheter will come out the next day. The only reason we leave the catheter in is so that you don't have to get up all night the first night of surgery, go into the bathroom, you can kind of relax in bed. Once the catheter comes out, I do want you to get up and start walking. You should be out walking, at least to the door 3 times a day, if not in the hallway. If the nurse isn't prompting you to do that, just give them a call. Say you would like to go for a walk. They'll remove all the stuff so you can go for your walk. The drain will stay in until you leave. The drain, anytime we do a procedure on the urinary tract where there's like potential for like a urine leak where we're opening up the urinary tract and then closing it again, we leave a drain in just to make sure that if there is a leak, which is also less than 2% chance, but if there is a leak, that drain takes care of it. We just leave the drain in for a couple of weeks, it closes up and it's out versus being a whole ordeal if there's a leak and you don't have a drain. So we just watch that drain output until you go home. Almost always, 98% of the time, that drain comes out before you leave. So just not to be surprised when you wake up for surgery, there's a drain coming from your abdomen. All right, have a good day.